So the topic is the DCB coating embolization. Okay, we have to understand if this is a real issue or only, let's say, a marketing part of some companies. There are many ways to characterize DCBs, okay, and to classify them. Okay, everybody likes to do classifications. One is, as you know, paclitaxel and sirolimus. Another one is a crystalline and a non-crystalline formulation, also known as amorphous one. Okay, since the very beginning, the vast majority of DCBs were with a crystalline formulation. So in the US, so far, we only have Agent, which is crystalline. Then we have the Sequent Please, which was the first one with the PacoCat technology, as a big crystals of the DCB, and the company decided to go on also with the Sequent sirolimus with a similar formulation of crystalline, with a quite high dosage of sirolimus as compared to other balloons. And then the Prevail is a balloon that comes from the Impact technology from Invatec. It's a very, very good technology with some improvements. And then we have the Pantera. Pantera looks, which is quite similar to Agent. And then we have the Essential Pro, which labeled their crystalline formulation as a microcrystal, because they claim that the crystals are lower in terms of size, are smaller in terms of size, but still crystals they are. And then we have no crystalline formulation. We have the Restore, which is so far the only DCB eluting paclitaxel available with a good market share in Europe and globally. And then we have the Solution and the Magic Touch, which are the two most available sirolimus coated balloons with nanotechnologies and micro reservoirs. But this is the classification. The first point in question is a non-crystalline formulation able to deliver a sufficient amount of drug to the vessel wall, specifically paclitaxel? The first studies and the first technologies, as I said, did investigate the crystalline formulation. So with the crystals, the big crystal staying in the vessel wall, they were able to show that there was a good amount of drug to be delivered into the vessel wall. And the doubt was that an amorphous or non-crystalline formulation wouldn't be able to do that. Actually, this motto has been changed in this study, published a few years ago. So this study showed clearly that the non-crystalline formulation of this paclitaxel-eluting DCB was shown to lose less drug on the surface, but by maintaining a very similar quantity of drug transferred to the vessel wall, which is good, because if you don't transfer the drug to the vessel wall and if you don't leave the drug on the balloon, you may argue that the drug is delivered outside and may go into the distality, into the microcirculation, either for coronaries or also for peripheral arteries. But this is an area where you don't want to lose any drug. And actually, many studies done 15 and 20 years ago by the same group of Aloki with the Rino Virmani did show that paclitaxel-based formulations, including stents, were associated with the findings of paclitaxel in many organs, including the liver, the spleen, and the lungs. And then there is another concept, which is something I would like to investigate with you, which is the potential distal embolization. Let's do a step back and discuss about primary PCI. It's not uncommon to see during primary PCI a very good result in terms of vessel patency, which is not associated with a good distal flow. Because that's clear, we know that clearly that a good distal flow, the fast symmetry flow, is associated with a sufficient amount of blood and oxygen and all of the nutrients to the microvasculature and then to the muscle. This is something that we need to avoid. So we need to obtain. Sometimes we get a very good result with primary PCI, either using thrombus aspiration or not, we put a perfect stent, there is no dissection, but still the flow is bad. And the cause for that is that parts of the plaque, including the thrombus, did embolize distally, causing this no reflow or slow flow, which has been associated with impaired clinical outcome. And then there is the topic of distal embolization in after drug-coated balloons. There have been several case reports showing an acute, with the crystalline formulation specifically, acute distal embolization and no reflow or slow flow. And I will go through a case that I performed a couple of years ago, which is showing something very similar with a crystalline formulation paclitaxel coated balloon. And I know that after my presentation, Aloki will present his animal studies, so I'm not going into the details of their findings on what's going on, what's happening acutely if you use a crystalline formulation versus a non-crystalline formulation drug-coated balloon. So this is a case, as I said, I performed a couple of years ago. This is a CTO of the LAD. You can see here, there is a stent implanted a couple of years previously. And it's a typical non-clear proximal cap that we needed to assess. This patient came for stable angina. So we tried to go into this cap and puncture it with a wire, but we were not successful. So we had to use IVUS guided puncture, which took us some time. But in the end, we were able to puncture the cap, thanks to the IVUS again, with a Gaia second wire. And we spent some time also in order to enter into this, the true lumen of this ISR CTO. Probably the Gaia second was touching the metal of the previously implanted stent. And of course, at that time, we were not able to understand which was the cause and the type of the plaque within the ISR, because we were not able to do IVUS. But in the end, with some support, also with a microcatheter, we use a caravel here, we were able to navigate through the CTO and then advance also in the distal bed of the vessel. Then we had to exchange our wire within the microcatheter using a Gladius Mongo, which, as you know, is a polymeric guide wire which allowed us to go into the distality of the vessel. Quite successful. Once we were sure about being in the distal part of the vessel, we started normal PTCA. We use a standard 1.5 balloon and then a 2 balloon in order to make room and to try to understand which was the cause for this ISR CTO. This is the result after a 2 balloon. Then we started using larger balloons. Probably you have already discussed with Neus and Dr. Hospital how you should do a DCB PCI in terms of prolonged inflations and to not rely on just predilating, because you have to rely on having a good angiographic result, and in this specific case also using imaging. And then we of course repeated IVUS to see what type of plaques we had within the vessel. Then we went on with again post-dilatation. We saw that the stent was not correctly expanded, so we post-dilated with a scoring balloon. We used a trio scoring balloon at high atmospheres, and then this was the final result after having predilating also the vessel distally, because the CTO did extend also in the distal part of the vessel. Then we used 2 paclitaxel crystalline formulation DCBs, okay, at 2.0 and at high atmospheres and at 2.530. And then this is what we observed just after the crystalline formulation paclitaxel. I showed earlier a good result after lesion predilatation with a good telemetry flow, and this is what happened after just delivery of 2 long crystalline paclitaxel coated balloons. This is a clear impairment of the distal flow, which we thought was related to crystalline embolization of these 2 long devices. We waited for some time, patient was asymptomatic, but still after some time there was some slow flow. The TIMI was much better, TIMI flow was better, but still the flow was not optimal. Then we were able to solve the problem with the adenosine. We used 200 micrograms here. Okay, and then we used, this time we decided to change the strategy. We didn't have Restore available in the lab, so we used the sirolimus coated balloon for the ISR segment, but for sure non-crystalline formulation DCB, and this was the final result of this revascularized CTO. This is just to show that in real life, specifically in complex settings like the CTO, but we can extend these also to acute coronary syndromes and thrombus-containing lesions and very long lesions. These are settings where in my clinical practice, I'm not using long paclitaxel crystalline formulations DCB for these reasons. Anyhow, we wanted to show also in humans and to try to confirm the initial findings of these case reports that I told you about, and also these initial findings from these studies in animal models. This is why we did a sub-analysis of the Piccoletto 6, which is called Piccoletto 6 an expert in DCB angioplasty. This is the de novo study in small vessels, and for this sub-analysis in the MIRE, we wanted to compare the performance of a crystalline versus amorphous or non-crystalline formulation DCB. In the amorphous group, we had 126 patients treated with Restore Magic Touch and solution, whereas in the crystalline formulation, we had several types of paclitaxel coated balloons. And then, after this initial assessment and comparison between crystalline and amorphous, we wanted also to compare the acute performance of paclitaxel and sirolimus coated balloon. The primary endpoint here is an angiographic-derived primary endpoint, which is called angiography microcirculatory resistance, or AMR, which is an index which has been correlated to IMR, and it's obtained by quantitative flow ratio at estimated flow velocity. There are several studies addressing the performance and the quality of this measurement, which has been compared to IMR, and all of the analysis have been done by an independent core lab independent from our foundation, which actually did sponsorize this investigator-driven study. This is the total population, as I said, 224 patients, 126 and 98. You can see here that there are differences. For example, in the amorphous DCB, the lesions were more complex. 72% of the lesions were versus 45% were considered complex by the core lab, and also the DCB length was different, 32.5 millimeters in the amorphous versus 26.4 in the crystalline formulation, and the difference was significant. First of all, we obtained a change in this AMR, which again is a measurement of the acute impairment of the distal flow after PCI, which has been analyzed a few minutes after PCI. So in all of the DCB PCIs, there was an increase in AMR, which overall was 0.7. And then when we compare the two groups of a crystalline versus non-crystalline formulations, we show that the crystalline formulation DCB was associated with a higher delta in this AMR, 0.9 versus 0.53, which was almost double this impairment, acute impairment in the distal flow. And then we wanted to compare if anything would be related to the different drugs, but actually we didn't see any difference between sirolimus and paclitaxel. Of course, sirolimus here was represented only in the amorphous group, but there was no statistical significant difference between the two groups. So there is no effect related to the drug, but the effect of this acute impairment was related only on the type of coating, crystalline versus amorphous. And then we did a subgroup analysis which showed as we hypothesized and as we have shown in the previous cases, that this delta in AMR is much higher in the acute coronary syndrome, and there is a specific detrimental effect between the association of a crystalline DCB and ACS. In this specific setting, the AMR was 1.61, whereas in the ACS plus amorphous DCB was 0.5. And there is no difference between the amorphous DCB used either in ACS versus chronic coronary syndrome, whereas the difference was huge with the crystalline formulation in ACS. So, very hypothesis generating. I would like to discuss with you about these preliminary findings, but I have some take-home messages that I would like to share with you. First of all, acute impairment of distal coronary flow embolization may jeopardize the result of any specifically successful and complex PCI. As I said, this is particularly detrimental in the acute coronary syndrome in primary PCI setting, but also after a long CTO case like the one that I showed, this might have a role. Crystalline DCB are associated for sure with an increase in distal embolization in animal models, and in this study, in Piccoletto 6 Mire, the delta in AMR increased significantly from baseline to post-angioplasty, but not at follow-up with DCB treatment at a greater extent with the crystalline formulations. Of course, this is a multifactorial event. We have seen an increase after any DCB PCI because there is some plaque that go distally, and the clinical effects of these, if they are persisting, if they are associated on the long term with impairment in the clinical situation of the patient, is not clearly understood. So for this reason, further randomized studies with larger populations, in my opinion, are warranted to confirm these very preliminary findings.